Our next presenter is Dr. Raed Awaisheh. He will present a case of complicated left main PCI. تفضل.
Thank you very much. I will go through the case. This is a 53-year-old gentleman who's diabetic with family history of ischemic heart disease, and he's a heavy smoker, same as most of the citizens in Jordan. He was admitted with acute coronary syndrome in 2015, and he had 2 stents in the LAD. At that time, it was discussed with him to go for CABG, but he refused that time. After that, he had another coronary angio. I did it for him, distal left radial, because the right radial was totally occluded. And it was also difficult, but there is no time to present the first two angios, because this one is a really long one. So in 2019, he developed angina. He was maintained on medical treatment and given ticagrelor of 180 milligram and taken to the cath lab. And this is his coronary angio. And as you can see, he has significant instant restenosis and significant stenosis in the LAD after the stent in the LAD. Also another lesion, discrete lesions, but really very distal in the OM. And the point is, once I engage with the diagnostic catheter, the left main, the blood pressure drops down, and the heart rate even went down. So he had indicating that he has also an ostial or left main disease. The RCA is small. So this is the case, and I was planning to go and just do PCI to this instant restenosis and stenosis after the LAD. The patient was given, as usual, the 10,000 heparin, and I started the PCI by doing the instant restenosis in the LAD. But as I told you all the time, once I go there, the blood pressure, the guide catheter sucked in, and the blood pressure went down. So to finish my procedure or to be able to do the LAD, I decided to do also the left main. So the first thing I did is dilating the left main, so I'll be able to comfortably complete to finish my PCI in the LAD. I return back to the lesion in the LAD. I fix it there. Also the instant restenosis after multiple dilations, and then stented there another stent. So the LAD is acceptable now. And I went back to the, left main and to fix the left main, because as you saw before that most of the black shift went to the circ. So I like to dilate the circ and then to stent from the left main to the left circ. I took the view of the iliocranial to go with the stent to the ostium, exactly ostium, this is the view. And then I have stented the left main. The ACT was observed all the time, and the ACT was not conclusive. One of the results was not accurate, the other one was too high. And this is after stenting left main to left circ. Any comment, Suhail?
Did you consider that she was having the left main before, or just during the manipulation with the catheter?
From the diagnostic, from the beginning, from the first injection in the left main, just from the first one, the blood pressure went down.
Ostial circumflex has stenosis? I don't see that.
Yes.
Yes, sir.
Yes, please.
Mic on.
The mic is
anatomically a problem.
You're absolutely right.
So I think just looking at this, I mean, the law of bifurcation is left main equals to 0.67 LED plus circ. So here you have a smaller left main than either. So I think even without imaging, you know that you're starting with pathology in the left main.
You're right. That's why he has left main from the beginning, and that's why we discuss with him the surgery again and again. And I think my colleagues in the past, they discuss with him surgery because of this left main disease.
How about the LAD, osteum, or the LAD after you did the circ stent, left main circ stent? I think it's not healthy. It looks like a pressure lesion or haziness.
مش شايفته. Okay. By anyhow, now we have the, maybe you are not able to see it, but there is a filling defect in the proximal part of the LAD, and the ostium of the LAD is not that good. So I was to deal with that one. Look at this.
I have a thrombus.
Now the thrombus is there. So the ACT was followed. The patient was given heparin and heparin. The ACT, we got another machine, and the ACT was not giving the accurate result. Sometimes giving it high, sometimes giving it low. And now when you are inside the cath lab and doing a left main PCI with these burdens of clots, so I decided to go and put the stent there and to do the keloid technique. No, there was no stent there. The stent is after that. That segment was without a stent. So after stenting these, still you can see it is not that healthy and locks some clots here and there. Look now. More clots are there. I think the clots are more obvious now in the left main toward the left circ. So the patient, till this moment, received 30,000 of heparin. So the decision was now to give intracoronary. So I give the heparin, intracoronary heparin, and intracoronary glycoprotein 2b3 inhibitor. After giving this, have better outcome, and you can see the clots now almost disappeared. So I continued my PCI with doing the proper kissing. And the proper flaring, and the final pot. And now this is the final result. The LAD is fine, the left main I think is good, and this is the final result.
I think, Raed, the most important finding is that a radial guy like you is doing the procedure from the femoral artery.
This is the third angio. My take-home message, if you would like to continue with this. The usual cause of clots in the coronary arteries is the formation of the clots inside the catheter flushed with the contrast to the coronaries. This is the most common cause of the clots. And the most common causes of a clot formation during PCI are low ACT, so you need to give more heparin. You need to check the cannula, because sometimes the cannula, if you give the heparin intravenously, you need to check the cannula that maybe sometimes it is out, and have some cases like this where the blood doesn't heparinize. And if the ACT, as in this case, is not accurate, so give the heparin as much as you can in the coronary, inside the coronary arteries, and give glycoprotein 2b3 inhibitor inside the coronary arteries, which was successful in this case, and I think this is the most important message. And you need to investigate the patient after that for heparin resistant and for thrombophilia.
Right, if it was, as you think that it was just anticoagulation problem, with that you cannot determine what the level of ACT or your problem with that, why to do this very complex procedure with keloid technique on the left main?
Yeah.
And just to give the anticoagulation, antithrombins, and to wait and see what will happen after that.
This is the point. When you are inside the mud, you don't have decisions. You need to save things and go out from the mud. And the way to go out from the mud is to use oral tools. And the tools is the drugs, and the other tool is mechanical. You saw that the lesion, the ostium of the circ was diseased with a black shift that was not a clot, and then the black shifted to the ostium of the LAD. So you cannot leave that with a thrombus burden. So you need to go with 2 stents technique and to do the culot.
And what's your DAPT now? Discharge plans, dual antiplatelet therapy.
Exactly. He's on ticagrelor and aspirin. I think he has sort of heparin resistant. I did not investigate him because he lives outside outside Amman actually, and till now he did not come back. But he keeps doing the follow-up with the GB there. And before getting this conference, I asked his GB there, and he said that he's doing fine, but he's still smoking.
That's good. That's good.
A question for you.
Yes, please.
Why you said the patient refused the gap, right?
Yeah.
But you see that he has restenosis. I think we can convince the patient that would be restenosis also in the current steps. So I think cabbage is the best way for this guy.
I promise you, next time when he develop problem, I will refer him to you, convince him, if you're able to.
Any question from the audience regarding this case, the panel, comments? Thank you, Raed.
Thank you very much.
Very good case. We have actually 5 minutes for any comments about the cases presented, how to treat, what to do in patients with the acute syndrome. We have
دكتور سهيل
good
I
case.
have one word on.
احنا في
I
عندنا
don't have
في عندنا
one word.
سيمبوزيوم بوست بعد هي اخر حاله كانت احنا عندنا سيمبوزيوم الكل يكون موجود يعني وبعديها في عندنا غداء.
I have one point about SCAD. The unlucky females who come to a hospital who do not have cath lab facility, and then you treat them with thrombolysis that might worsen the picture, because these patients will have further dissection. So STEMI in a young female, as other cases actually, not necessarily female, should be referred to a nearby cath lab facility. But this particular subgroup of patients, when you give them thrombolysis, sometimes they can die actually from VTAC and arrhythmias. And also when they go home, probably some people talk about you don't need to give them DAPT, dual antiplatelets, because it is not atherosclerosis. It is just a dissection into a sick media of the vasculature.
I recently had a case with the female. She was 50 years old. She came to the ER with some chest pain, and the ER doctor was going to discharge her home. But because she was a relative of somebody, they got her admitted, and in the ICU she showed the full ST elevation in the anterior wall, and she fibrillated. And we have to cardiovert her. Of course, you have to take her to the cath lab. I took her, and there was occlusion in the mid-LAD, almost proximal, and with very tortuous LAD. The picture, you look at it, it looks as in any patient with ST elevation myocardial infarction with a totally occluded LAD. But knowing the scenario that happened and the anatomy of the vessels and all the tortuous coronary that she has at 45, you can swear that was some sort of SCAD. And really, nobody knows what to do with those patients. But if you have somebody with this elevation with the VF at the same time, you can't leave it. You can't take the risk and not to do intervention to stent this patient. Thank you for the interesting panel. And we'll start exactly at 12 for the second session.